Okay, today I was going to talk to you about the H1N1 influenza virus in pregnancy and talk to you about other immunosuppressed patients and what the future is looking like. So our learning objectives today will be to understand these complications during pregnancy, find out how we're going to prevent and treat these in pregnant women, and develop a strategy so we can recognize it early, because the key is prompt antiviral therapy. So as some of you may know, the H1N1 2009 influenza A originated from a avian flu, a human H3N2 flu, then the classic H1N1 that dates back to 1918 epidemic, and then a Eurasian swine flu, and through a series of 20 years we now have the H1N1 2009, which emerged. Okay, so to give you examples of how these viruses present, this is a leukemia patient who on baseline has a clear CAT scan of the sinuses, and then a week or two later, while in the hospital, she gets a respiratory illness, and clearly there is brand new fluid in the sinuses. The bronchial walls are thickened, so we got some bronchitis here, and a little more bronchial wall thickening here and here. And then down at the bases we have some atelectasis and possibly some early ground glass pneumonia formation. And she did fine as she was started very early on Tamiflu. Now, unfortunately, some people don't have that easy of a course. This patient illustrates that. She is 52, Hodgkin's allo stem cell transplant over 2 months ago, has fevers, muscle aches, cough, sinus congestion, was exposed to a sick grandchild, and despite this illness for 7 days, here's the key, no treatment was begun. So by the time she shows up to our center, it's now been going on for 2 weeks. She gets progressively short of breath, hypoxic, respiratory failure, requires a ventilator. Bronchoscopy shows the H1N1 flu and aspergillus, so the co-infections are key. So here's her x-ray initially, and then here it is towards the end, and she dies of ARDS. And that was the last x-ray there. You can see the lungs whiting out. This is a typical H1N1 viral pneumonia pattern with focal ground glass infiltrates, which progressively got worse with some degree of consolidation. Now, one of our training fellows in St. Pete sent us this case, who's a 35-year-old female HIV positive, CD4 490, so not bad immune system, came into their hospital with shortness of breath and rapidly progressed with ARDS, ventilator dependence, respiratory failure, strep pneumo, and blood and sputum. Flu screen negative, which is a common theme, but the PCR is positive and dies of flu-like ARDS picture. So this was the patient's x-ray, who also died of the ARDS picture. Okay, now what are the x-ray patterns for the H1N1 influenza 2009? On an x-ray, patchy consolidation is found half the time. Lower and central lung zone infiltrates on 71% of the time. Ground glass infiltrates 25% of the time. If they wind up in the intensive care unit on a mechanical ventilator with severe disease, over 3 lung fields will likely be involved, so this is multifocal. The CT chest, when that's done, ground glass with the consolidation is found in the vast majority, or just ground glass only. So those are the typical findings, not pathognomonic for H1N1. That could be found in any viral pneumonia. Interestingly, what were called nodular opacities were found in almost half the cases. And then here's another big thing that people should be aware of is pulmonary emboli occurred in over 1/3 of the cases. So pulmonary emboli are also part of the picture. Now, when they looked at autopsies of patients with the H1N1 flu, Diffuse alveolar damage was the #1 finding pathologically. Necrotizing bronchiolitis was found in over a third of the cases. Remember, RSV is classic for necrotizing bronchiolitis, so is this H1N1 and other viruses. Extensive pulmonary hemorrhage. One of our pulmonary colleagues mentioned that if the bronchoscopy shows lots of blood, like a pulmonary hemorrhage, those people tend to get better with steroids. Now, this isn't published, but it's pretty much felt that steroids do not help people with H1N1, but if there's a lot of hemorrhage, then possibly like a diffuse alveolar hemorrhage, they would benefit from steroids. So that was someone's comment we need to take into heart. That was published, American Journal of Respiratory Critical Care. Fibrin thrombosis and vascular lumens, necrosis of bronchial walls. Remember the PE phenomenon there? New England Journal, 2009. Tracheitis, bronchiolitis, diffuse alveolar damage, and another series of most of the 34 patients from the archives of Path Lab Medicine. Now, as you remember, the vaccine priority list that came out, guess which one was #1? Correct. Pregnant women was the #1 group. And then 2 were household contacts, caregivers of children younger than 6. Then came the healthcare workers, the emergency medical system personnel, and then children from 6 months to 18 years. Now we're getting a little older here. And then the young adults 19 to 24 were the other big key, and then 25 to 64, and then anybody from 25 to 64, and then 65 and older was sort of the last group. So, what are the most common risk factors for flu complications? Well, this California study had over 553 patients with confirmed or probable H1N1, and of those people that were sick, they found that chronic lung disease, asthma, or COPD was in 37%. 17% were immunosuppressed, cardiac disease in 17%, pregnancy 17%, diabetes 13%, obesity was another big finding with this H1N1, that was in 13%, and that was published in the MMWR 2009. Okay, so that was a very important article to get a feel for this. Now, when we look at specifically studies looking at pregnancy, they looked at 34 women that had the H1N1, and 6 of them died of ARDS from April 15th through May 18th during this period of time, and that was published in Lancet 2009. So that was some of the first studies coming out about what happens in pregnant women. There was an increased risk of severe flu, particularly during the 2nd and 3rd trimesters. So that was another one. That was on this internet access site. 100 pregnant women required ICU care in the U.S. as of August of 2009. 28 died. So those are, young, healthy women other than their pregnancy. 28 died. So that's a pretty big number there. And that was also at that internet site. Now, spontaneous abortion occurred in 1 at 13 weeks of gestation, and a premature rupture of membrane at 35 weeks of gestation occurred in 1, and that was MMWR 2009. Okay, so complications of swine flu. They estimated that 2 to 5% of confirmed cases were in the U.S., which is a level of 0.3% estimated. Canada had a similar level, and Mexico was about 6%. The most common reason for admission to the hospital was pneumonia and dehydration. So hospitalization, you could see, was not common if you think of 0.3% in the U.S. But when you were hospitalized, you usually were young, and you don't typically get sick of the flu. So that was the scary part. There was rapidly progressive pneumonia, which I gave you examples in our 3 cases. 2 cases, respiratory failure and ARDS. So those are the big ones. Interestingly, you may have patients which may not be any more common than the regular flu, or might be a little more common, is influenza-associated encephalopathy and encephalitis. So that's already been reported. And then multiple pulmonary emboli is sort of a new phenomenon that we really didn't know about in the past. And that was New England Journal of Medicine article. And another one mentioned the same thing. So pregnant and postpartum women from the 2009 California article, 4 times greater risk of ICU admission and death if you delay treatment more than 2 days from the illness onset. So that's the number one take-home message is pregnant women sick with a flu-like illness, don't wait for the testing. Give them the Tamiflu right away for H1N1. So 94 pregnant women versus comparing 137 non-pregnant women of reproductive age, 8 postpartum less than 2 weeks women with H1N1. Okay, so that was 94 pregnant, 8 postpartum versus 137 non-pregnant. 95% of the 94 pregnant women were in their 2nd or 3rd trimester. 34%, big factor here, also had other risk factors for a bad illness other than pregnancy. So that's, a third of the patients. The ICU admission was in 22%. 18 were pregnant, 4 postpartum, and 8 died. 6 deliveries occurred in the ICU, 4 emergency sections, and that was hot off the press, New England Journal of Medicine in 2010. Again, some of the things they also discovered from this California study is that 10% of those hospitalized or died of H1N1 were pregnant in California from the April through August, and that was published in JAMA of the 1088. Less than 14% of pregnant women get the flu vaccine. That was old data that basically they weren't getting vaccinated. That's another important point, is that to really push pregnant women to get the flu vaccine. 38% false negative rapid antigen flu tests, so don't rely on these rapid tests is also another important point. If you suspect it, treat it. And then here's a big one, rapid clinical deterioration. 25% that required mechanical ventilator were severely ill and intubated at presentation. So these people are sick from the get-go, okay, very fast. And then the H1N1 flu was more likely than the seasonal flu to have a higher severity in pregnant women, and that was in that New England Journal 2010. Okay, so if you think of pregnancy and how that affects the pulmonary function test, no surprise, as you become larger in the abdomen with this pregnancy, the minute ventilation goes up, the oxygen uptake goes up, and the basal metabolism goes up. And then if you look at this, notice over time as your abdomen gets bigger, your chest size is shrinking, so your total lung capacity is shrinking, and then all of the other components, whether it's your vital capacity, etc., starts shrinking, inspiratory capacity, etc., residual volume, all of them are shrinking towards the end of pregnancy. Now, another important point across the board is, what were the bacterial infections with this H1N1? Well, empyema has been reported, necrotizing pneumonia, bacterial co-infections, ventilator-associated pneumonias, and 20% in the Australia-New Zealand study, ICU admitted for H1N1 had a secondary bacterial infection. That's a lot. So 20% admitted to the ICU with H1N1 had a secondary bacterial infection. What were these bacteria? Which were the most common ones? Well, no surprise, strep pneumo 10, group A strep 6, viridin strep mitis 2, staph aureus 7, and then MRSA, gram-negative rods like H flu and other gram-negative rods, and aspergillus, MMWR 2009. Epidemiology of the pandemic of 2009 as of October 20th. 53% hospitalized with H1 flu are under 25 years of age. That is totally different than seasonal flu. Okay, 7% hospitalized with H1N1 are 65 and older, whereas seasonal flu it's 60%, sort of opposite. 23.6% of the deaths are under 25. 65% of the deaths are, look at that group, 25 to 64, and then 12% are 65 or older. where it's the exact opposite for seasonal flu, 90% are over 65. And that was in CID 2009. Now, with pandemic H1N1 influenza, looking at almost 5,000 hospitalizations between April 15th and July 24th, the cut down was 0 to 4 years of age, the young child, 23%, 5 to 24, the older child, young adult, 26.7, and then 25 to 50 was almost 7%, and then a little older, 4%, and then over 65, 1.3%. If you look at the 292 deaths from the H1N1, you can see that, notice the young are the big ones, especially the 25 to 49, which would include pregnant women, of course, would be in that category as well, and then 50 to 64, and then finally the over 65 was not as high as it normally is. Now, when they've done modeling studies of the H1N1 in the U.S., 140 times greater cases than reported from this modeling cases. So they came up with 2 to almost 6 million cases in the U.S., 9 to 21,000 hospitalizations, and the CDC modeling study estimated 47 million cases with 213,000 hospitalizations between April and November of 2009, and you could find that at that website. Global estimates were saying that the H1N1, before it's all said and done, 2 billion people will be infected, with about 30% of the population affected with H1N1. So this is a major pandemic. Okay. Now, for treatment of the H1N1, oseltamivir or zanamivir as soon as possible improves survival in the critically ill, and that was in the JAMA article. Resistance to amantadine, ramantadine was well known. We do remember that, unlike the seasonal flu, which has the opposite sensitivity, which is sensitive to amantadine, ramantadine, resistance to the oseltamivir. Now, this was also published in New England Journal of Medicine, is that you should consider increasing the dose of the oseltamivir, doubling it, and prolonging the duration from 5 to 10 days if it's severe or progressive pulmonary illness. If the patient cannot take the IV peramivir and the inhaled zanamivir were recommended, and that was New England and Lancet discussing that. Antibiotics, of course, are necessary for the community-acquired pneumonia, the staph, the MRSA, the group A strep, the pen-resistant pneumo, MMWR. Now, what about swine flu in the elderly? If you were born before 1957, you have pre-existing immunity against other similar viruses. So 33% of individuals over 60 had titers over 160, compared with 6% from 18 to 40 years of age and 9% from 18 to 64. So the older person had some immunity. Another one looked at titers over 160 correlated with at least a 50% decrease in the risk of influenza infection or disease. Yes?
When Mulring was here, he mentioned that this may be well better known, I think, that the reason why the elderly weren't quite affected is because the original 1918 influenza A stuck around in the population in the 50s. So a lot of elderly people have this pre-exposure to influenza, to the Spanish flu, which is very similar to the H1N1.
Very good, thank you. So in the 50s, the circulating viruses were giving people protection, so that's where that came from. Now, ECMO for pandemic H1N1, extracorporeal membrane oxygenation, first used in a case in Michigan, had limited success. A case report of successful ECMO in a 21-year-old woman 4 months postpartum with diabetes, poorly controlled, and developed respiratory failure, septic shock, required pressures, ejection fraction 5 to 10%, Zosyn, Zyvox, Tamiflu, ECMO. Cultures grew Staph aureus, Aspergillus glaucus, and H1N1 by PCR. Weaned from ECMO at hospital day 10, extubated hospital day 11. Went to rehab on day 22, 98% sat on room air, eventually full recovery with normal ejection fraction. So there you have a successful ECMO treatment. And that was published in the Emerging Infectious Disease. Now, here's a larger ECMO study from the Australia-New Zealand cases. 68 patients with the H1N1 with ARDS received ECMO. Mostly young adults, severe hypoxia. Median duration of ECMO was 10 days. 21% mortality rate, and that was published in JAMA 2009, November. Here's some future considerations. Number one, oseltamivir effectiveness decreased significantly, but not zanamivir for H1N1 during 2008-2009 flu seasons in Japan, or actually for the regular flu because it wasn't around 2008. So the thought was that you can use zanamivir for viruses that are oseltamivir resistant. Genetic polymorphisms are very important because, for example, indigenous people in North America, New Zealand, and Australia had a 3 to 8 times greater hospitalization rate and a 4 times greater mortality with the H1N1. And so that tells us that different people groups have different genetic polymorphisms, and they may have a worse outcome. Sort of like coccidioidomycosis. If you're Filipino, Oriental, African American, you may have a worse disseminated infection, cytokine storm kind of picture. So the host response is important. High virus replication in the lower respiratory tract causing this cytokine dysregulation causing the ARDS, very similar to the avian H5N1 virus was occurring. So what they found is the H1N1 has a propensity to go into the lower respiratory tract, which makes it more dangerous. Okay. Here's another one was high virus replication, or excuse me, immunomodulators such as statins, 54% lower risk of death with prior flu, not necessarily the H1N1. So theoretically, should be true for the H1N1. And they found that those that were taking statins, the percentage of those hospitalized deaths were dramatically lower, and that was in an IDSA abstract recently. Also, some people have speculated we could take the plasma from those that recovered or got a good vaccination antibody response and then use that to treat patients to neutralize the bug. High dose corticosteroids generally not recommended, New England Journal of Medicine. However, it's intriguing to think about whether they have a component of DAH. Would that help? Or would low dose steroids like they do for ARDS help? That remains to be seen, but that's speculation. And then of course ECMO seems to possibly be another adjunctive therapy we can use. And that's all I have for today. So that's the latest updates on H1N1 in pregnancy. Thank you.